thank you all for coming today. I know it's a busy time of year, so I appreciate you making the time to come out to the talk. And thank you in particular to all those at the Center for Global Health for the invitation to come and talk today. I'm going to talk mostly about diarrheal diseases as they relate to climate change. And I'll spend about the first half or so of the topic of the lecture kind of talking in fairly broad terms. And then the second half, I'll zoom in and talk a little bit about a study that I conducted with a number of collaborators. It is. Are you getting it? Okay. With some collaborators in Ecuador, where this photograph is taken, trying to untangle the kind of complex relationships between diarrheal diseases, rainfall, and access to water and sanitation. And if you do have any questions, please feel free to ask either during the talk or at the end. So the IPCC has, over the past 9 months, been releasing the IPCC 5 reports. This quote is from the physical science basis that was released in September, and their statements were quite strong, saying, that there's essentially no doubt that the climate is warming, and these changes are really unprecedented. We are now at over 400 parts per million concentration of CO2 in the atmosphere, which has never previously been experienced in human history. The atmosphere and ocean are warming, the snow and ice are diminishing, and sea level is rising, which has a number of implications for a number of different sectors, but we're going to talk mostly about how it may impact health. In this report, the Impacts, Adaptation, and Vulnerability Report was just released at the end of March. This is the second of 3 reports. The third report was released, I believe, last week on mitigation. But this report really deals with what the potential impacts of climate change will be on human systems, everything from agricultural productivity to urban planning to health. And these are a few of the quotes from the report. And I think what's interesting is is kind of how they've structured, or how they kind of structure the long and short-term potential impacts. So if you look now, the health effects of climate change currently have been fairly minimal compared to other health challenges. In the future, kind of in the next 40 years, we expect the health impacts of climate change to really be seen in terms of existing and known health impacts that will be essentially dialed up. So from everything from heat stress to diarrheal diseases and vector-borne diseases. Over longer timescales, it's harder to predict exactly what will happen, but it's possible in some areas normal human activities will be compromised. This is essentially the most probably striking idea here is the fact that in some areas it may be just too hot for people to farm or be outside for extended periods of time, which has enormous impacts, particularly in the occupational health sector. There may be the emergence of new conditions, particularly one of the big concerns is emerging infectious diseases, although there is considerable uncertainty about what this may be. And then finally, diseases may expand their range. So we may see diseases like dengue in areas where we haven't previously seen them over longer timescales. And this is kind of the inventory of potential health impacts. And you can think about them, first there are potential impacts due to heat waves and flooding that are immediate. So this is everything from injury and death due to extreme heat events or extreme weather events. And it's important to note there are a number of mental health consequences that can come out of extreme heat events when communities like Tacloban in the Philippines experience an extreme cyclone. That not only has immediate health effects, but can have long-term mental health sequelae given the trauma of being displaced. There's an increased risk of undernutrition due to shifts in agricultural productivity. It's important to note that some areas, like Canada, may have increased agricultural productivity, but other areas may have decreased agricultural productivity. And we think the net impact will be negative. That will overall net loss, but this is very place-specific. There are consequences for lost work capacity and reduced labor productivity due to other health impacts and due to factors like extreme heat. And then there are increased risks of food and waterborne diseases, which is what we'll largely talk about today, and vector-borne diseases due to the potentially shifting habitat for vectors such as mosquitoes. And then there will be some positive effects as well. There could be decreases in cold-related mortality and morbidity, and there could, as we talked about, be an increase in food productivity in some areas, which may have benefits to health. However, the net effect is thought to be largely negative. So the next question is kind of who is going to be most impacted. And what we think is that the largest risks will apply in populations that are currently most affected by climate-related diseases. So areas that are already experiencing morbidity and mortality for example, heat-related diseases, areas that have, or populations that suffer from food insecurity, populations that are impacted by diarrheal diseases. Essentially what we'll see is a dialing up of the severity of disease and death and disability in these areas. So this is a global distribution of diarrheal disease. Diarrheal disease is a highly discriminatory illness in that it is very much concentrated in some of the poorest areas of the world. You can see the concentration in Central Africa here on this map, where the highest burden of disease is seen. There are a number of foci throughout sub-Saharan Africa. In Southeast Asia, India has a very high burden of diarrheal disease, and then in some limited parts of Central and South America. And so, you know, why should we care about diarrheal disease? We'll talk later about some of our uncertainty about what the relationship between climate change and diarrheal disease may be. But one of the reasons we're so concerned about the potential impacts of climate change on diarrheal disease is just the importance of diarrheal disease right now as a global source of death and disability. So this list here is the leading causes of death and disability measured in terms of disability-adjusted life years in low and middle-income countries. This is a report that was released in December 2012 by the Global Burden of Disease Study. And the number one cause of death and disability are lower respiratory infections. Number two is diarrheal diseases. This is in lower and middle-income countries. You can imagine the distribution in high-income countries is very different. And in children under 5, you can see that this is a study of the causes of death in children under 5, that diarrhea is the second leading cause of death in young children. So diarrhea is really affecting the very young, kind of some of the most vulnerable in our populations. And you know, while much of the emphasis is on deaths from diarrheal disease, I think it's important to note that diarrheal disease has a number of insidious consequences. This is a very old study done in Guatemala in the 1960s that shows the growth trajectory of a child. This is the normal age for weight curve, and you can see this child starts off on the healthy growth curve and rapidly falls off, and at the end of this eventually dies. And what happens here, this child has a diarrheal episode here, gets an upper respiratory infection, has another diarrheal episode, another diarrheal episode, another diarrheal episode. And you can see this chronic diarrheal disease, either repeated infection or sustained infection, causes a failure to thrive, a failure to grow. You know, there's enormous interplay between diarrheal diseases and respiratory infections, that one can cause susceptibility to another. So we talk about diarrheal disease as being a disease of poverty, and it not only affects the most poor in our population, but also can really be a disease that helps sustain poverty, in that kids who are repeatedly suffering from diarrheal disease may not grow, may not learn, may not be able to attend school in the same way as kids who are healthy. So it really can reduce growth and development. So what do we mean by diarrheal disease? Generally mean, the WHO definition is simply 3 or more loose stools, 24-hour period. There are a number of things that cause diarrheal disease, everything from stress to taking antibiotics to some chronic conditions. But what we're really talking about here are the infectious causes. A recent study has highlighted 4 leading causes of diarrheal disease. The study is very controversial, but rotavirus, cryptosporidium, enterotoxigenic E. coli, and Shigella are some of the leading pathogens causing diarrheal disease. And I think that the important point here is that when we think about diarrheal diseases, it's not one pathogen. It's not one causal pathway. There are many different ways, many different pathogens that can cause this health endpoint, and these pathogens can be, have different characteristics. And we think about how temperature and rainfall may impact the transmission of disease. The impacts may be very different on, for example, rotavirus than they may be on Shigella, which makes our life a little more complicated. And just to talk briefly about how the infectious diarrheal diseases are transmitted, essentially diarrheal diseases are transmitted by the fecal-oral route. I apologize to all of you who are eating lunch right now. We'll talk about, diarrheal diseases are essentially occur when people eat human or animal excrement. And that is something none of us usually does willingly, but it can happen. It can happen when open defecation occurs, so that waste does not make it into a sewage system. Waste can get on hands, it can get into food, and end up in, the human host. Some of the people who might be particularly vulnerable to this pathway are both young children who have lots of hand-to-mouth behavior, and mothers with young children who are changing diapers and trying to tend to other children and cooking food and have 10 million things pulling them in a million directions. Water and sanitation are enormous solution here, but even when waste gets into sewage and latrine systems, they, if not properly managed and contained, can get into surface and groundwater, which can get into drinking water, or people can get exposed through bathing in surface water systems as well. So there's a number of potential routes, but essentially, it's this getting to the human mouth that is the problem. So there's a number of ways we can prevent diarrheal diseases, many of which are extremely low tech. Washing hands is considered the self-vaccination. If you wash hands, you can block transmission to yourself and to anyone for whom you prepare food or may otherwise expose. Safe water supply, so talking about pathogen-free drinking water supply, something we often don't think about as much, but is the abundance of water. So this may not be water for drinking. This may be water for washing, water for other household tasks. This water often does not need to be as clean as drinking water. But you can imagine, in a household that has access to 100 liters of water today, the hygiene behaviors may be very different than a household that has access to 10 liters of water a day. Safe sanitation is containing human waste and preventing it from getting out into the community, and safe sanitation means not only having a toilet, but, in many places we see toilets that are over lakes or rivers, and that really is not safe sanitation. And finally, exclusive breastfeeding. This is the intervention that appears kind of on both lists. Both exclusive breastfeeding can prevent child exposure to fecal pathogens because formula is not being prepared with available water supplies. Exclusive breastfeeding can also boost immunity. So if children are exposed, they are slightly more resistant to the pathogens. There are 2 very effective, relatively new vaccines, one for cholera and one for rotavirus, and micronutrient supplements are also promoted as ways to prevent diarrheal diseases. So there's a number of interventions, many of which have been quite effectively applied in some areas. So let's shift to talking about climate change. And I feel like I'll propose that there are kind of 3 ways in general that we kind of approach climate change and health. And I feel like the first way is kind of this like banging your head on the desk or putting your head in the sand and being like, this issue is just too complicated, it's too frustrating, it's too political, we're never going to get anywhere, and I just can't deal with it. And while we are all in this room, and I imagine are much more hopeful than that, I I think everyone at some point kind of throws up their hand and may feel this way. The second approach to kind of thinking about climate change and health is really that, okay, climate change is happening and it's a potential problem, but we have far too many other problems to deal with. And this really is just not, high enough on the priority list to be here. And you could pull some of the IPCC report and justify this approach. IPCC says that at present, the health impacts of climate change today are pretty small relative to other health problems that we are facing. However, if we look forward, climate change has the potential to be a major impediment to continued health improvements worldwide. And I think, as part of the global health community in particular has, a large sensitivity to vulnerable populations and commitment to addressing the health needs of very vulnerable and neglected populations. And I think these are exactly the populations that have the potential to be impacted by climate change. The people most vulnerable are the very young and the very old. They are people who are already experiencing climate-related diseases, everything from malaria and dengue to heat-related illness. These are populations dealing with food insecurity now that really won't be able to deal with a greater level of food insecurity in the future, populations that are currently living in poverty, and generally those populations kind of with the least tools to adapt to changes in their community. So I would, argue that climate change really needs to be part of the global health agenda. And the approach that many have adopted is kind of this idea of how do we identify vulnerable populations and intervene to reduce their risk. So if we return to this map of diarrheal diseases in the world, who on this map is most vulnerable to increased diarrheal diseases due to climate change? Where is the risk going to be greatest? I'll just throw out this language here so we're all speaking the same language. The mitigation is usually the term we use to talk about reducing CO2 emissions. Adaptation is the approaches we refer to adapt to a changing climate. So the changes that are going to happen that will not be dialed down because of mitigation will require adaptation. And finally, vulnerability is the degree to which a system is able to change and adapt to the adverse effects of climate change. And there's kind of a new push to switch the word vulnerability to resilience, which has a much more kind of positive tone in creating community resilience. So what are the potential impacts of climate change on diarrheal disease? Let's kind of drill down and talk in some more specifics. Well, in general, if you look at the literature, temperature looks like it may increase pathogen survival. So if you think about a defecation event that happens on a surface, if it's warmer, the bacteria may survive longer, which just gives a longer window in which people may be exposed to that pathogen. And a study done in 2011, which compiled 5 studies of climate change and temperature, did show that there was generally kind of a positive relationship between increasing temperature and diarrheal diseases. But the picture is not quite so simple, because in general for rotavirus, we see higher rotavirus loads in cooler seasons, both in the tropics and in northern and southern areas. So that this relationship may depend very much on the pathogen itself. And this Kolstad and Johansson paper that was published in 2011 really concluded that one of the greatest challenges to understanding the potential impacts of climate change and health, and particularly diarrheal disease and climate change, are uncertainties in our understanding of the empirical relationships between climate and health. Excuse me. So what about rainfall? Rainfall is expected to increase in some areas, decrease in other areas, and severe rainfall or heavy rainfall events are overall projected to increase. So it may be Wet areas make it wetter, dry areas make it drier, and when rainfall does occur, it may occur in more severe concentrated episodes. So if you look at this picture, this is taken from the field site in Ecuador. This is a latrine. The river has flooded. The river here is a large source of water for drinking and also for washing clothes and other activities. People use the river for transportation as well. So there's high potential for exposure to the surface water in the river. And the fact that this latrine is now flooded is not great news. There's all sorts of pathogens that were captured in this latrine that now may be mobilized. This is another, I'm not sure if this is the same event or a different event, same area. This woman is walking through the flood water, and you really don't know what's in the water. I mean, this is something we all thought about last September when the floods were occurring here, is what exactly is in this flood water? What have the floods captured that may be here? I think it's also important to think about drought and its potential impact on waterborne diseases. This woman is hauling water in an area in China where I do work. And you can think about if water supplies are limited, if your household tap goes dry, how does that change your behavior? How does that change health protective behaviors like hand washing and sanitation during food preparation? It can have enormous impacts, and there are studies showing that kind of the further people have to travel to get water, the more adverse outcomes you see in kids in terms of growth and development. So in general, the evidence for looking at rainfall and diarrheal diseases shows a positive relationship between rainfall and diarrheal diseases, but there's a lot of exceptions there. In the U.S. and Canada, we've seen heavy rainfall events are associated with waterborne disease outbreaks. High and low rainfall have been associated with diarrheal disease in the Pacific Islands and Bangladesh. And flooding has been associated with diarrhea in a number of areas, but not associated with diarrhea in other areas. And there's a really neat study from actually 1978 looking at a drought that happened in the UK and showing increase in diarrheal disease in kids in daycare centers due to limited water. But there's some uncertainty here about what's happening, and I would argue kind of there are a lot of challenges here in terms of unpacking what these relationships and these kind of statistical associations mean mechanistically. If you think about risk due to climate change, you need three things. You need a hazard, so we need to know, for example, that temperature really does dial up the increase of, let's say, E. coli. You need an exposure, and you need a vulnerable population. So, you could have a relationship between temperature and E. coli, but if the temperature never gets above X, maybe there's no risk presented. Or you can have exposure and a hazard, but no vulnerability. The population has, abundant access to safe water and sanitation, good food preparation standards, and you have no risk of disease. So you really need all three to have a risk of climate change. And analytically, I think this makes things a little more challenging because, understanding the relationship between some climate or weather phenomena and disease also requires you to take into account vulnerability. And so this is the model we have kind of employed in our study in the in the Ecuador cohort, is really trying to understand how climate exposures impact diarrheal diseases, taking into account vulnerabilities. It's the idea that, in more vulnerable populations, we'll see greater effects, and less vulnerable populations will see lesser effects. So let's talk about the Ecuador study. This study was started in the early 2000s in northern coastal Ecuador. It's an area that's driven primarily by this river system, which you can see here in greater detail. And in the early 2000s, late 1990s, a road was built into this area. So the origins of this study were actually looking at the impact of road construction on the distribution of enteric pathogens. And the studies work in this area has been going on for over a decade. It's led by Joe Eisenberg at the University of Michigan. We kind of opportunistically came in. There was active surveillance for diarrheal disease had been conducted, and really wanted to ask, and there had been all these community assessments of access to water and sanitation and community structure. Could we try to understand something about the relationship between climate and diarrheal disease? And because this is such a water-based area, we really decided to focus on heavy rainfall events. And we had two hypotheses. One was that heavy rainfall events are associated with diarrheal disease, and they are most strongly associated with diarrheal disease in following dry periods. That there was this sense based on time on the ground that the worst diarrheal outbreaks potentially happened after it had been dry for a long time, and a heavy rainfall event occurred. This may be because, in the dry period, what my colleague loves to call a fecal film would build up in the community because rainfall has not removed animal and human waste, so that when rainfall does occur, you get a pulse into water systems. And then we had a second hypothesis that was that community vulnerability, and we'll talk about what that means, may modify the effect of heavy rainfall and diarrheal diseases, that more vulnerable communities may be most impacted. So we talked about floods already, but let's talk about how we measured diarrhea incidence. Diarrhea is somewhat difficult to measure. You can use clinic data. The problem with clinic data is obviously only the more acute cases present to the clinic, which has pros and cons. We used an active surveillance approach. Weekly surveillance was conducted by a series of community health workers in 19 villages over a 3.5-year period. And while these data are imperfect, I have to say, and I can say this because I had no involvement in the collection of this data, I came in after the data had all been collected. This is an enormous effort, and I really think, while we would love to have 20 years of active diarrheal surveillance data, 3.5 years of active surveillance data in an extremely low resource setting is something that I think is a real strength. We used the WHO definition for diarrheal disease, so we asked if anyone in the household had 3 or more loose stools in the past week. The study included about 5,000 people monitored over about 400,000 person weeks. And the incidence of diarrhea was about 4 cases per 1,000 person weeks, so less than 1 case per person, or one case per person. No, less than 1 case per person per year. In children, the incidence was not surprisingly higher, 13 cases per 1,000 person weeks in kids under 5, which is kind of what we would expect. We monitored rainfall in the area. We put loggers in 4 areas, in the Bourbon, which is kind of the area, the lowest lying area where the rivers drain to, and then 3 of the outmost villages. We use these data logging rain gauges that are, as you'll see on the next slide, both amazing sources of automated rain data collection and enormous sources of frustration. The rain gauges break or clog, on occasion leading to gaps in the data, which you can see here. So what we did is to get rain data for all villages over all times, we first imputed the missing data from the rain gauges and then interpolated over the surface of the 19 villages. And we defined heavy rainfall as 1-day rainfall in the past 7 days that exceeded the 90th percentile value for that region. So this is place-specific. One of the things we talk about a lot in terms of climate change is relative versus absolute changes relative versus absolute temperature and precipitation. This idea that, Arizona may be better able to withstand a 110-degree day than San Francisco, because San Francisco just really doesn't ever experience that, so that you look at a relative change. So this is a place-specific definition. And then we looked at long-term rainfall patterns to look at kind of dry versus wet periods and use average rainfall over the past 8 weeks. And this is what average rainfall over the past 8 weeks looks like for each of the 19 villages. And I think the thing to notice here, which I was initially very surprised to see, is that while there is this distinct dry and wet season, it is not the same every year. So if we had used this month-based definition of rainy season and dry season, probably would have kind of led us astray, because you can see The dry season's really starting, let's say, in September here. It really started in July or August here. And in 2006, it never really got that dry. So that there is enormous annual variation in rainfall. And we used percentile values to define low, medium, and high rainfall being above this line. And then we looked at maximum one-day rainfall in the past week. And this graph is a little bit busy, but essentially shows maximum one-day rainfall in the past week for each village. The dots are rainfall events that are over the 90th percentile, so what we're considering heavy rainfall events. The black dots are heavy rainfall events that occurred during relatively wet periods. The blue dots are, the red dots are rainfall events that occurred during relatively dry periods. And then we had 4 measures of vulnerability. 3 of them are kind of the obvious water and sanitation definitions, access to an improved or actually any latrine, drinking water treatment. Did you treat your water in your home? So this is not how clean is the water system, but what happens once the water gets inside your house? Do you boil or chlorinate or filter? About 29% of people in our cohort on average reported treating their drinking water. Hygiene behaviors based on this score that health workers gave when they went to the home. And then we used a metric of social cohesion. We had the privilege of having an anthropologist on our study who was very interested in kind of how community structure impacts health. And so this metric was designed to kind of get a sense of how strongly the community was bound together. So people were asked in a typical week, I believe, what's the number of, who do you spend time with outside of your family? And so communities that are more connected have, people report spending time with more people. And then communities that are less connected, the number is lower. And we used 2 statistical models. So one, we said, diarrhea is going to be a function of heavy rainfall and long-term rainfall, and these are interacting variables. So that, the impact of heavy rainfall on diarrheal disease depends on whether it's wet, medium, or dry in the past 8 weeks. And then we also looked at, to test our second hypothesis, diarrhea is proportional to, whatever is happening in terms of rainfall, interacting with vulnerability. So this idea that, the impact of heavy rainfall events depends both on long-term rainfall and on social vulnerability. We, prior to doing the analysis, kind of decided that really only 1 or 2 week lags would make sense. So we really don't expect that the second rainfall occurs, that people become ill, that there is some sort of lag. And a number of studies have looked at all sorts of lags. But we really thought that, there could be a 1 week lag, there could be a 2 week lag, but longer than that time scale, it would really be hard to mechanistically justify a longer lag. So what did we find? Well, first of all, we found evidence that during low rainfall periods, the risk of diarrheal disease is increased by heavy rainfall events if you use a 2 week lag. We saw absolutely nothing when we look at a 1 week lag. And very interestingly, we found during relatively wet periods, heavy rainfall events were actually protective against diarrheal disease. So the incidence went down. One thing we kind of expected, the second thing we didn't. And then we looked at vulnerability as the effect modifier. And this shows, and these graphs take a minute to kind of piece through. This shows on the x-axis the percent of households that treat their drinking water. This graph is for periods when rainfall in the past 6 weeks has been low, so the relatively dry periods. And what you could see, the y-axis shows the relative risk of, or the incidence rate ratio of diarrheal disease attributable to heavy rainfall events versus non-heavy rainfall event weeks. And you can see the risk of diarrheal disease is elevated when very few households treat their drinking water. And as the number of households treat their drinking water, increases, you see a decrease in risk. So this is kind of as we suspected, that when more households treat their drinking water, these negative effects of heavy rainfall go away. What's interesting is we also see that in relatively wet periods, we essentially see almost no protective effect of heavy rainfall events. But as the percent of people treating their drinking water increases, the protective effect of heavy rainfall events also increases. So this interaction, reduces the risk conferred by heavy rainfall events in the dry season and increases the protective effect in the wet season. Interestingly, and we were somewhat surprised to see this, we didn't see any protective effect of sanitation, hygiene, or social cohesion. None of these were statistically significant, and sometimes people ask me, well, this is P is 0.08, that's kind of close. And I think it's important to remember we're doing several hypotheses tests here, so this is probably, if you were to do a Bonferroni correction or somehow adjust for multiple hypotheses being tested, then this is really not significant. While the sanitation and diarrheal disease relationship was really not significant, and I don't think we can say much about it, I do think it's interesting that the trend is of increasing risk with increasing sanitation rather than decreasing risk with increasing sanitation. I don't think you can hang much on this because it's not statistically significant. One of the things we've been thinking about is whether in communities with some sanitation, but sanitation like the ones you saw in that picture of the flood, which is probably, a pit latrine, not really well dug, not well protected, very vulnerable if flooding occurs, may actually concentrate pathogens in a single area. So if those latrines do get flooded, they may actually have a harmful effect on the community. Certainly something worthy of further investigation. I'll note there are a number of limitations to this study. One, we use self-reported all-cause diarrhea, and while I think it's a really strong data set, it just cannot capture any of the nuances of relationships between rainfall and different diarrheal pathogens. We imputed our rainfall data, pretty standard practice, but again, imputation always, adds a level of uncertainty. We would expect that uncertainty to bias things to the null, so it's conservative. We measured water, sanitation, and hygiene once a year, and one of the things we think is that water and sanitation and hygiene behaviors may change seasonally, particularly if you think about how people obtain their water. That may be very different in the rainy season where you could put a bucket outside or underneath your roof to gather water than if, in the dry season where water sources may be more limited. So that's something we're very interested in kind of evaluating is kind of the more micro changes to water and sanitation and hygiene behaviors. We only measured social cohesion every 3 years, and while we think social cohesion is a pretty stable measure, there's also possible that it was just too, measured at too large an interval to really capture some of the subtleties here. And I think the question that I'm most interested in is really how do these findings generalize to other areas? Is this finding really specific to these 19 villages in Ecuador, or is this relevant to other places? Do other places see similar or very different effects? I think what you can say in conclusion for this study is that heavy rainfall events are associated with diarrheal disease following dry periods, and negatively associated with diarrheal disease, and decrease the risk of diarrheal disease following wet periods. And that drinking water treatment really did appear to kind of dial down the risk conferred by heavy rainfall events in dry periods, which suggests that possibly the way in which heavy rainfall events are impacting diarrheal disease transmission is through drinking water. And, as we talked about early on, the pathways by which people acquire diarrheal pathogens are not simple, and water and sanitation are kind of intricately tangled, but certainly it suggests that drinking water treatment may be an adaptive measure that may help reduce risk of climate change, at least in this region. I wanted to just mention the floods that happened here, because, I mean, I think one of the temptations is to say that this is a very abstract, kind of far away problem. And we became grossly aware that, you know, heavy rainfall events can impact us here. You know, the amount of rain that fell in these 3 days was larger than the maximum monthly record previously set in Colorado. And I think that, you know, not just that heavy rainfall events can occur here, but, you know, there are questions about how water and sanitation and rainfall can interact to cause diarrheal diseases. And while, you know, in some ways we have you know, very sophisticated water and sanitation systems, a number of areas in the Colorado area were under boil orders for their drinking water. You can just think about, you know, what kind of sanitation system this house has. You know, do they have septic? Is the septic compromised? Do they have sewer? If they have sewer, are the pipes broken? You know, at least in Denver, I know our water is far more chlorinated, or apparently they're still dialing up the chlorination levels in Denver because of fear over pipe breaks and leakages caused by the flood. So this, you know, while we've talked about this much more in kind of a low resource environment context, I think there is relevance here as well. You know, I'll kind of end by talking about a couple of things, but I think this quote from the IPCC is really telling that climate-related hazards really exacerbate other stressors, especially for people living in poverty. So if we want to think about how climate change is going to impact health, we can kind of look to the people who already have kind of the most stressed health environments. And these have the potential to be most impacted. And I have really talked almost exclusively about adaptation and kind of how climate change may impact health. But I think, you know, this question is an open one, and one we all, I think, kind of have to grapple with, which is what is our role as public health professionals, as practitioners, as, you know, global health practitioners? What is our role in mitigation? The IPCC just released their mitigation report a couple of weeks ago, and it's certainly a source of ongoing debate about what can be done. And I think this image from the most recent report is a really interesting one. Although complicated, it frames the Earth into kind of 3 spheres. So that you have social stressors in yellow, you have a resilient space in green, and then you have biophysical stressors. This is essentially climate change in red. And the greater the resilient space and the smaller the biophysical and social stressors, you know, the better off you are. And you can think about kind of these different decision points that can be made, both in terms of adaptation and mitigation, to either, you know, increase the resilience of a community, to decrease social stressors, to decrease biophysical stressors, and have, you know, a potentially low-risk situation or lower-risk situation. You can think about decisions that really can lower community resilience and creates this very small space in which people are able to kind of dial up or down their risk, because there is so much other competing social stress and there is so much biophysical stress. And I think, you know, this can include everything from public health infrastructure to war to nutritional, you know, food systems and other components. So I just wanted to acknowledge that this work is, you know, not my work alone, and that there are many people who have kind of worked on this project together. The work was largely funded by NIH, R01, and actually an NSF EID, I think, was the first thing, and then most recently an R21 from Fogarty. Carmen Campagna and the team of health promoters in Ecuador really made the diarrheal disease collection possible. And Karen Levy is the PI of the most recent grant. She's at Emory and works very closely with me. Andrew Wooster is a student I work with who has done an enormous job of kind of searching through the literature. And we're currently trying to put together a systematic review. And then all the members of the EcoDust team, including Joe Eisenberg, who's the PI. Jim Trossel, the anthropologist from Trinity, and our collaborators in keto, Jason Goldstick, who is the analyst, and Amanda Markowitz, the graduate student who wrestled with all these data sets and actually made sense of them and kind of did a yeoman's work. So there's a number of resources, and I think these slides will be available on the website, so we won't go through these. But certainly a lot of work has been done, but a lot of work remains. So thank you all for your time and attention, and if you have any questions. Dr. Stories.
Thank you for the great lecture, but also intriguing work on the effects of increasing sanitation and increased diarrhea. It makes me think a little bit of what happens with hepatitis A. Sometimes when we see the more sanitation we get, the more risk of getting worse hepatitis A outbreaks actually. And so, were you able to in any way, or can you look into the age effects of those diarrhea episodes? So one thing that could be happening is, if you're in a very low sanitation environment, you get exposed to pathogens very early, and you develop, quite a robust immunity very early on.
Mm-hmm.
You either die or survive, and those that survive tend to have very good immunity. And as your sanitation improves, then you get more episodes of diarrhea just because you're not being exposed as frequently. So.
Yeah, I mean, I think that's a really interesting point. We didn't have enough kids in this cohort, or enough, child time, essentially, to look at that. We really wished we did. But I think it just kind of drives home this idea also that place and context matters a lot in thinking about this, that the health impacts of poor sanitation may depend very much, and who is impacted may depend very much on kind of what the baseline conditions are in the community. Are you exposed at a young age to pathogens? Or are you in a relatively clean or low pathogen environment, so that you're much more vulnerable if exposed at older age? So yeah, I mean, I think this point well taken. Yeah.
I was wondering about the deadly spiral between malnutrition and diarrhea, and certainly a priori malnutrition is going to make a population more vulnerable. Certainly, we know that post a single diarrhea episode, you're more likely to malabsorption and malabsorptive diarrhea, sugars and others. So, how might that have impacted your study?
That's interesting. I mean, we really didn't look at nutritional outcomes at all. I think they do have some nutritional data from a much smaller portion of the population. But again, I mean, I think it does get to this kind of place specific and I think it's why I think it's interesting to think about how you could, how this translates to other areas, because the food and kind of nutritional security in this area may be very different than another region, and that may impact their vulnerability to climate-related diarrheal diseases. So that it gets back to this kind of what makes a community vulnerable. And I think if you wanted to be, if I wanted to be simplistic, you could argue, well, this is across this community, the food access is relatively homogeneous. I'm not really convinced that that's true, but I don't know kind of how to take that into account. But certainly something worth thinking about, because I think that kind of deadly spiral, as you say, is quite compelling. And it's something that we haven't talked about as much, but that there are kind of overlapping impacts of, if climate change causes increased rainfall events and decreased food security, you can kind of get this double hit as well. It should be, more than the sum of the parts.
Excuse me. So based on your results, do you have plans for follow-up studies or intervention studies?
Well, lots of plans, but currently working on the funding end of things.
So if there was funding.
If there were funding, yes. I actually don't know what Karen Levy in Ecuador is doing a follow-up study, kind of looking more specifically kind of at following pathogens through water supplies in Ecuador. And then we're also trying to strategize kind of where else we could look at this. Yeah, thank you. Yes.
I appreciated that you looked at social cohesion as a possible factor in doing find a relationship, but I'm just sort of curious what you were imagining you might find, because I could picture, people people's social cohesiveness, improving their education level, improving their resiliency. But I also could see more potlucks where people are putting their fingers in each other's food.
So they actually, the number of measures that they have more measures than just the one we use. That they do have a food sharing metric, and I actually don't know what they've found from that. But what's very interesting in this area, actually, let me just see if I can pull up the map. Is that, so this is kind of the city, which is not a very large city, but relatively large city. And these are the most remote villages. And the most cohesive villages, as you may imagine, are villages that are further upriver. And they've found, so it's kind of complicated to untangle because these are also the poorest villages, the most isolated, least access to care. But when adjusting for a whole host of variables, they found evidence that actually these villages kind of have that social connectivity is protective against diarrheal diseases. So we expected it would be protective, but not what we found.
I was thinking there also could be a smaller scale, like with the heavy rainfall, maybe you have fewer potlucks and people aren't playing outside, and so the heavy rainfall, the really heavy, could kind of keep people out of some of the trouble.
Yeah, absolutely. I mean, it also may work at a scale that we're just not able to capture. I mean, one of the things that Jim Trossel was really interested in is how communities are able to respond if flooding is about to occur. Can they get organized, put up sandbags, and protect more, or get people out? And maybe that's not kind of the scale of or that maybe the outcome is really not diarrheal disease as much as kind of life saved or injuries or other things that we could look at. So, well, thank you all for your time. I appreciate it.